Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, friends and colleagues. I would like to welcome you all to this joint activity between the Emirates Cardiology Society and the Emirates Diabetes Endocrine Society. And today we're going to proceed with the part 2 of Cardiometabolic Academy. And I'm sure for those of you who had attended part 1 had enjoyed. We had around 500 attendees in part 1, and we look forward for your connection and also interaction with us during this session. And I would like also to take this opportunity to thank the effort which has been put in this program by my colleague and my friends, Dr. Hani Sabur and Dr. Wael Mahamid, and working on this for several months in order to bring this program to life. And also I would like to thank our sponsor, Novo Nordisk, for their unrestricted grant towards this continuing medical education. And I'm sure you're going to enjoy today's webinar. So I just have a few housekeeping that I just have to tell you about. Is the webinar is currently live stream on EDS, Emirates Diabetes Endocrine Society YouTube channel. And also it will be, the recording will be available on demand on the Emirates Diabetes Society website. And then you can see the website there, www.adsinstitute.org. And if you have any questions during the session, we will be taking the Q&A after all the presentation over. That's been after our third presentation, which is the case discussion. We're going to have half an hour questions. So if you have any question, please do not hesitate to write it in the Q&A chat box. Also, if you have any queries or any hiccups or glitches, or you have any queries that you want to ask from the support team, just feel free to WhatsApp them on the number which appear there. The activity is a CME accredited by Dubai Health Authority for 2 CME hours. Now, without delay, I would like to introduce my long-term friend, Dr. Khadija Hafid. She's a consultant physician known to many of you, and she worked at the Department of Internal Medicine and Diabetic Unit at Rashid Hospital, Dubai Health Authority. She's an associated professor and clinical tutor at Dubai Medical College, and Khadija had done also several, research in the field of the diabetes, and specifically her interest in the cardiovascular complication in diabetes and obesity. And Khadija today will be covering how to identify the cardiometabolic patients in United Arab Emirates. So Khadija, the floor is yours. Please unmute your mic and you can share your slide in a slideshow.
Are you able to, Assalamu alaikum, are you able to see my slides?
Not yet, Khadija.
Not yet. Okay, so let's try and do that. Stop share, and then let's try to share screen again. Are you able to see them now, Dr. Fathia? I'm having a little bit of resume share.
Not yet, Khadija.
Okay, so let's try a new share.
Button, Khadija, of the recording.
Why isn't it coming?
You're okay, Khadija. We can see your slide. Just
okay,
go to your first slide and just put it into the slideshow.
Okay, let's see here, and let's put it on play. All right, so is it visible now? All right, sorry about that glitch. Assalamu alaikum, everybody. And thank you so much for that lovely introduction, Dr. Fathia. And thank you for the kind invitation to participate in this very important webinar. I'm delighted to be with you this evening. And as stated, my task is to really discuss the cardiometabolic risk in patients with diabetes. So first, here are my disclosures. In the time allocated, what I would like to do is really highlight the burden of diabetes in the UAE, and then I will review some of the diabetes screening guidelines based on the Emirates Diabetes Endocrine Society guidelines, and then discuss the cardiovascular risk assessment and stratification. So the burden of diabetes was really elegantly and detailed highlighted by Dr. Hassanain last week for those of you who are able to attend. So just as a recap, I would mention here that the prevalence in the UAE is around 16.3%, and that's according to the latest IDF Atlas, that's the 9th edition that was released in 2019. And this was really based on a survey that was conducted about 2 decades ago in the age group of 20 to 79 years age group. Thereafter, there have been few studies on diabetes prevalence that have been conducted. More recently, there was the large population-based survey that was done in the Emirate of Abu Dhabi. This was the Wiqaya program. And in that survey, the prevalence rate was reported at 17.6% for diabetes and a staggering 27% for pre-diabetes. More lately, in 2018, we've had the results from the Northern Emirates, and this showed a really high figure of around 25%. What was even more shocking from that survey was that more than half of that cohort that was studied actually were previously undiagnosed. So whatever the figures are, whether we take 16.3 or 17.6%, we know that we have a huge problem with diabetes in the region. And therefore, it's really important that we are able to do population screening early and able to detect the cases earlier on. In order to do that, I will refer you to this document, a very important document, which is the updated Emirates Diabetes Society Consensus Guidelines for the Management of Type 2 Diabetes. It was published under the leadership of our chair, Dr. Fathia, last year with the help of many wonderful colleagues who worked tirelessly across the Emirates. Now, what about the screening for diabetes based on the new EDS guidelines? We've taken the ADA screening criteria, but we've chosen to adopt a younger age of 30 years. So we recommend that individuals above the age of 30 should already be offered the opportunity to be screened for diabetes. Adults of any age who are overweight or obese with one additional risk factor should also be considered for screening for diabetes. If the test results are normal, then repeat testing should be offered at least once every 3 years, unless, of course, the conditions change, or 6 monthly if the person is diagnosed with prediabetes. So what are those additional risk factors that we're referring to? So if you are an adult, overweight or obese, and obese meaning you have a BMI greater than 25, or for those of Asian descent with a BMI greater than 23, and you have a first degree relative with a history of diabetes, prediabetes is diagnosed, or you've got low levels of high density lipoprotein or high triglyceride levels, hypertension, physical inactivity, you belong to a high risk ethnic group, which is most of the population in our community. You've got history of cardiovascular disease. For women, if they've got evidence of polycystic ovary syndrome or they've had gestational diabetes, they should be screened for diabetes early. Other conditions that may also prompt the physician to screen for diabetes is any cutaneous markers of insulin resistance, such as acanthosis nigricans. So the criteria for diagnosis are really universal. We haven't reinvented the wheel. You might either use a fasting plasma glucose, and the threshold there is 126 milligrams per deciliter. Prediabetes would be diagnosed if the levels are above 100 but less than 125. If you're going to use the oral glucose tolerance test, then the threshold for diagnosing diabetes is above 200 milligrams per deciliter. For prediabetes, it will be the range of above 140 to 199 milligrams per deciliter. The preferred test is, of course, the hemoglobin A1C, and the threshold for diabetes is 6.5%, whereas for prediabetes in the range of 5.7 to 6.4. Why the A1C is more preferred is because it's quite convenient. It doesn't require the patient to come in fasting into the clinic, and it's not usually affected by any illness or stress at the time of testing. However, there are a few caveats that we need to also take into consideration. And that is some of the limitations of the test, because we know that there are certain conditions which may actually give you an inappropriately low hemoglobin A1C. And this includes situations whereby there may be either acute or chronic blood loss. There are certain hemoglobinopathies that are sickle cell, thalassemia, which tend to be quite prevalent in our community as well, may also give you an inappropriately low hemoglobin A1C. If the patient has had a recent blood transfusion or there's ongoing hemolysis, that might also affect the hemoglobin A1C and may make it difficult to interpret the levels. Certain drugs that we actually use in clinical practice quite often, iron, vitamin B supplements, low-dose aspirin, vitamins such as vitamin C and vitamin E can also inappropriately lower the hemoglobin A1C levels. Then there's other disease states, chronic liver disease, pregnancy, rheumatoid arthritis may also affect the level of the hemoglobin A1C. Then there's those situations that we need to bear in mind that may give you an inappropriately higher hemoglobin A1C. And that includes things like uremia, so when there's renal failure, or situations that may lead to a low red cell turnover, and B12 deficiency and iron deficiency is a good example of that. If the patient uses alcohol excessively, or there's evidence of hyperbilirubinemia. Drugs, again, high-dose aspirin, chronic opiate use can also inappropriately cause a higher hemoglobin A1C. Then rarely, we don't see that often in clinical practice, lead poisoning, but aplastic anemia and splenectomized patients may also have higher than usual hemoglobin A1C levels. There are certain situations whereby it may either be high or low, and that includes certain hemoglobinopathies and interference of the assay. So what about type 2 diabetes and cardiovascular risk? Because this is really what we are concerned about. And while we know that cardiovascular disease is really the leading cause of death among people with diabetes, and this is the same for both genders. Now, we can see here that the risk, if we compare patients with type 2 diabetes with matched controls over the years, the level of death from cardiovascular disease actually has been declining, but you can see that it is much higher in those patients that have type 2 diabetes. And in fact, we know that heart disease is the cause of death in more than 2/3 of people with diabetes that are above the age of 65. As a matter of fact, the presence of diabetes actually increases your risk for coronary heart disease by 2 to 2-fold. It increases the stroke risk by the same amount. It increases the risk for heart failure by 2 to 5-fold. And what is really apparent is the fact that there's no hemoglobin A1C threshold. So it is really a continuum. So what about the comorbidities of diabetes? Now, we know that a lot of patients with diabetes will also have hypertension and dyslipidemia and obesity. And these conditions are in of themselves also risk factors for cardiovascular disease. In fact, if we look at population surveys, we know that 90% of our patients with diabetes are really overweight, 70% of them have dyslipidemia, and 66% of them have arterial hypertension. Now, if we go on and concentrate on the global prevalence of cardiovascular disease in patients with type 2 diabetes, we can see that atherosclerotic cardiovascular disease really takes the top. But I'd like to draw your attention to the fact that heart failure, which we discussed quite extensively in the last webinar, is also something that we need to concentrate and pay attention to. Now, the other thing is that we've seen in large epidemiological studies that there's a large burden of risk factors, cardiovascular risk factors in patients in the Gulf region. And this is here just a snapshot of the Gulf race registry. And in here, it showed that 50% of the cohort were hypertensive, 40% had diabetes, and 40% were smokers. That's in the dark red lines. You can see much higher levels than in the grays, which were the Western registries. The other thing that was also apparent in the Gulf race registry is that the age at which the patients were presenting with an acute coronary event were a decade younger than the patients that were seen in the Western populations. Here again, just emphasizes the same thing, that if you look at the mean age, it was a decade younger than those in the West who were really 60 and above, and quite a high history of diabetes, 40%, compared to half, it was around 20% in the Western countries. More interestingly, we had a lot of information and insights from the Wiqaya program, which was a population-wide cardiovascular screening program for the Emirate of Abu Dhabi. And the mean age there was around 36 years. What was also very clear from this survey was that the rate of cardiovascular risk prevalence was quite high. Whether you looked at it as a crude prevalence or an age-adjusted one, you can see that central obesity, hypertension, prediabetes were all quite high. More lately, I came across this article, which was done by our colleagues in Al Ain, Dr. Jumal Kabi, where they looked at the prevalence of diabetes and the cardiometabolic risk factors in young men. So these were men under the age of 30. And what they found was that in this cohort of really young Emirati men, the prevalence of obesity, diabetes, impaired fasting glucose, hypercholesterolemia, all the dyslipidemias and hypertension were really quite highly prevalent. Because of that, then, we're not surprised when we see in the lay press such headlines as heart disease is a top killer in UAE. 30% of all deaths in the UAE are due to cardiovascular diseases. And on World Heart Day, younger people are at risk of heart disease. Diabetes patients are at high risk of heart disease. We're not surprised that we see these headlines in our newspapers. But despite having these really very eye-catching headlines, when we look at the surveys of our patients with diabetes, we can see that there's a very low level of awareness on the high risk of cardiovascular disease. So patients ranked foot issues, hypoglycemia, and amputation as more important, and there was a very, very low awareness on the level of cardiovascular risk. In fact, what was so shocking was that most patients thought obesity was a much more serious diagnosis than diabetes. And 34% of that cohort that was surveyed didn't even discuss cardiovascular disease with their physician. So let's look at how we can think about cardiovascular risk stratification. I'll first look at the European guidelines, and these were updated in 2019. And what they did was they tried to look at risk as moderate, high, and very high risk. So you have three main sort of categories. And the moderate risk included young patients with diabetes. So if it's type 1 diabetes below the age of 35, and for type 2 diabetes below the age of 50. Here, the diabetes duration was less than 10 years with no other risk factors. And then your risk got higher if your diabetes duration was greater than 10 and there was no target organ damage or and the presence of an additional risk factor. The very high risk category are now those patients with diabetes who've got established cardiovascular disease or evidence of other target organ damage, or they've got 3 major risk factors, and or those patients who've got early onset type 1 diabetes, so a duration of greater than 20 years. These would be considered in the very high risk. What about the ADA ESD consensus? I know that's a busy slide, but what I'm going to just draw your attention to is what they considered as indicators for high risk, and that's age above 55 with either coronary, carotid, or lower extremity artery stenosis that's greater than 50%, and the presence of left ventricular hypertrophy. Now that, you might say, is sort of the European, the American guidelines. What about our own guidelines? And therefore, it's important to look at that in the context of our own population. We've done our population studies. We know what sort of populations we have. And therefore, the beauty of this document is that we were able to tailor the guidelines based on the population demographics. And so we recommended, we used actually the ADA and the ESD as sort of a basis, but we modified it slightly in order to suit the population characteristics. And again, here, what I'm going to show you, the risk stratification is based on the age of the patient, the duration of their disease, and the presence of one or more multiple cardiovascular risk factors. So this is what the algorithm looks like, and I will start off with those patients with type 2 diabetes without cardiovascular disease, and we've broadly divided them into 2 age groups, those that are below the age of 50 and those that are above the age of 50. And you might say, why did we choose a cutoff age of 50? It's quite similar to the one that was used in the European guidelines. The American, the ADA one had 55, but as I will show you later on, as I'd shown you, most of our patients are succumbing to cardiovascular events at a very young age, and therefore it's important that we use this younger cutoff age. Then the next thing that you want to look at is the disease duration. So has the patient got diabetes for less than 10 years or greater than 10 years? And so if we look at the first column, the disease duration less than 10, we then go and look at the risk factors. If they don't have any risk factors or have just one single risk factor, then we would classify that as low risk. On the other hand, if they've got more than 2 risk factors, they fall into the moderate risk category. Then if you look at patients that now are above, they have the disease for more than a decade, again, you would do the same thing. Do they have risk factors? Yes, they've got a risk factor, moderate risk. So here, just on the basis of the disease duration and the presence of a risk factor, they move into a moderate risk as opposed to when the disease duration was less than 10 years. So we move on. If you've got more than 2 risk factors, already you're in the high risk category. Now let's look at the other side where the age is above 50. Again, we've divided that into the disease duration. So for those that are less than 10 years, with no or 1 risk factor, they would fall into the moderate risk category. And for those patients that have got more than 2 risk factors, they would fall in the high risk. When the disease duration is more than 10 years, 1 risk factor would make you fall into the high risk category, similar to somebody who's got 2 risk factors and disease duration of less than 10 years. And then if you've got diabetes for greater than 10 years, you're above the age of 50, and you've got more than 2 risk factors, then you fall into the very high risk. So now here, this individual who's above the age of 50 has got a disease duration that's greater than 10 with 2 risk factors, has got the same risk as an individual of any age with type 2 diabetes and evidence of cardiovascular disease or target organ damage. And the usefulness of this sort of algorithm is then to guide us onto the choice of therapy. So for those that are at very high risk, high or even moderate risk, it's important to select therapies that will be able to modify their cardiovascular risk. So the choices for patients in terms of their glycemic control, irrespective of what their hemoglobin A1C level is. If they're in the very high risk category, we need to select GLP-1 receptor agonist or an SGLT2 inhibitor with proven cardiovascular benefit. If then the glycemic control is still a problem, one might consider to add the other agents within the algorithm. And so for the high risk category, we've got the same sort of theme. You want to consider first the GLP-1 receptor agonist or an SGLT2 inhibitor, and then you can use the other agents as well if your patient has not met their glycemic targets. Likewise, for the moderate and low risk category, you can use any of the agents, but bearing in mind that you might want to consider other risks such as efficacy, hypoglycemia, what the impact would be on weight and the cost, and what the baseline hemoglobin A1C levels are as well. So I'd like to summarize my talk by reiterating that cardiovascular disease remains really the leading cause of death globally. 2/3 of the deaths in individuals with type 2 diabetes are attributed to cardiovascular disease. The problem in our region is that we've got a very low level of awareness on the high risk of cardiovascular among patients with diabetes. And thinking about risk factor modification is really essential in addressing cardiovascular risk in people with diabetes. Early detection and guideline targeted therapies are really important because we know they can help to reduce the cardiovascular burden in our patients with type 2 diabetes. I'd like to stop there and thank you all for your kind attention and hand over the mic back to our chair.
Thank you very much, Khadija, for this excellent presentation as usual. And I just want to remind the audience, we have around 400 audience connected with us now. I would like to encourage all of you, to type your questions. So we should have, a very interactive session at the end of all the 3 talks. And now it gives me a great pleasure to introduce our next speaker, Dr. Hassan Al-Tamimi. He's a professor of cardiovascular medicine at Mohammed bin Rashid University of Medicine and Health Science, and he's the head of cardiology department at Mediclinic Parkview Hospital. Dr. Tamimi will be speaking on the cardiovascular outcome trial in type 2 diabetes and how far have we come. Dr. Tamimi, kindly just unmute yourself and please share your slide and put them in a slideshow. Thank you.
Okay, good evening, everybody. Can you see my slides?
Yes, Dr. Tamimi.
Thank you very much. Dr. Fathia, thank you for the kind invitation. It's really a pleasure to be with you all. Thank you, Dr. Wael and Dr. Hani, for this kind invitation also. I think Dr. Khadija really set the stage beautifully to link the diabetes really epidemic with cardiovascular problems. So briefly, this is a slide from a friend of mine, Dr. Verma, that diabetes affects the pump, the pipes, and the filter. Literally, it's a panvascular disease. And as you heard previously, that the majority of complication of diabetes has to do with cardiovascular issue. So pump, looking at heart failure, pipes is the vasculature, and usually we look at the MACE as an outcome, and the filter is the renal disease. These 3 parameters are critical in the way we approach management of patients with diabetes. Now, identifying the problem is very good. Identifying the risk is excellent. The issue is need to treat it. And I think for a long time, despite the excellent control of hemoglobin A1C by our colleagues, the endocrinologists, it didn't have much impact on the cardiovascular outcome, except for some microvascular issue. Until recently, and actually it's by accident, that some trials were done to assess safety of newer diabetic medications. And we ended up with two amazing classes of drugs that literally has changed the way we look at not only diabetes, but cardiovascular disease, and in particular, heart failure. And these two classes, the GLP-1 receptor agonist and the SGLT2 inhibitors. Now, both of them, one by increasing satiety and working on the gastric motility, reduce the food, you get loss of weight and subsequently low glucose and low hemoglobin A1C. The other one looks at the filter. It impacts the reabsorption. It blocks the reabsorption of glucose in the proximal tubule, therefore reducing the sugar reabsorption, and therefore has an impact on glucose. Well, I think to our benefit, we have come to assess these effects. And as I said earlier, usually we design medications for certain particular disease. Now, through the clinical trials, we are understanding these medications and trying to understand how they work in order to get out the benefit that we see. So therefore, I want to first touch on the GLP-1 receptor agonist. And this is a review by Drucker in the Cell Metabolism. And actually, this is some sort of hypothesis. We are, because these medications have shown some amazing benefit, and this particular class on the vasculature, then you talk about the impact on increasing vasodilatation, plaque stability, decreasing inflammation, and so on. These has to be the mechanism that possibly can explain some of these trials. Now, these are 6 GLP receptor agonists, and these are cardiovascular outcome trials. Initially, they went exploring the impact of these medications on in patients with type 2 diabetes. And as you can see, I summarized them all. The number, quite good number, age, similar age, and the kidney function, it seems to be fine. Now, the prior cardiovascular disease is important. Some of them has 100% secondary prevention, and others have more of a primary prevention. And these are the parameters: 3-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke, all-cause mortality, heart failure hospitalization, and the renal effect, and of course the weight loss issue. Now, all these green boxes reflect significance. And as you can see, this trial, Alexa, did not show any impact on these parameter outcome, while LEADER, using liraglutide, 9,000 patients, there was a significant impact in reducing 3-point MACE, cardiovascular death, all-cause mortality, which is quite significant. Again, you go back to semaglutide, less, you have some benefit, and so on. So some studies showed no significant benefit, others show quite a robust benefit. And of interest, none of them have any impact on heart failure. This is important because we then happen to know which class of medication working on which. So primarily, 3 major trials, the LEADERS, SUSTAIN 6, and REWIND, have shown significant impact on MACE, and then some have shown cardiovascular death impact reduction here. SUSTAIN showed a non-fatal stroke, and REWIND on the non-fatal stroke. So most of these benefits are primarily vascular. And as I said earlier, none of them has any impact on heart failure. Now, if you pull all these trials together, and you can do somehow, because it gives you an idea about the whole class. And you can see, if you look at the risk of MACE in all these trials, still the significant and the non-significant, you get quite a significant overall impact in the MACE. If you go back to the cardiovascular death, similarly, some have a significant impact on cardiovascular death, others did not, and the pooling, the overall is significant here. You can see the p-value. Again, the fatal or non-fatal MI, again, significant, and fatal and non-fatal stroke. So despite having this variation, I think it may be related to patient population variation, the design of the trial, but as a whole, this class of drug, of course, we would go along with these trials that have shown significance. As a whole, this class of drug has a major impact in the cardiovascular outcome, particularly that has to do with the vascular aspect of things, which can be explained by the initial slide that I showed you, impacting inflammation. You can put all these theories. Despite this benefit and the impact that these trials have done, the prescription rate of these medication has not matched the excitement and the enthusiasm that we had. And I'm focusing here as a cardiologist, the purple line, it's really not much existent here. And even though the endocrinologist also the prescribing rate. Now the issue here, these medications do not reduce hemoglobin A1C as other anti-diabetic agents. And therefore, I think there is a dichotomy between reducing A1C, which is an immediate effect that you can see when your patient come back to your clinic, and reducing outcome, which is a long-term aspect. I think we have to, like we do with blood pressure, you need to reduce the blood pressure correctly, but you need to use the medication that reduce blood pressure and improve outcome. So we have to have this in mind. So those medications may not reduce hemoglobin A1C as effective as the others, but their benefit is far outweighs the other agents. One other aspect is the injectable. We are not used as a cardiologist to inject. I think this is one of the inhibiting factors, particularly in those which you have to inject daily, and we have also weekly. But the good news is these agents now, they can be in the oral form. I think there's a mechanism or technology that prevent these being digested in the stomach and being absorbed in the intestine. So that's a huge improvement in making these medications available and easy to administer to the patients. One major issue that I see that will make a big impact is using the medication in patients without diabetes. I think, as has been said before, diabetes has a major impact on the whole vasculature. But when you have a medication that can work and improve outcome, regardless of having diabetes, that makes this medication quite globally used. And I think this trial, the SELECT trial, is enrolling patients without diabetes, 17,000 patients with established cardiovascular disease. So we need to dissect the benefit of these supposedly diabetic medications by removing diabetes from the picture and see what do they do on the vascular level. This trial, I think, will be a major implication on this class of drugs, and particularly when you have the oral form of them. So for summary for this part of my talk, GLP-1 receptor agonist benefits appear to be related to reduction in multiple types of atherosclerotic vascular events. Efficacy is consistent across cardiovascular endpoint trials and among primary and secondary atherosclerotic cardiovascular disease population, because they were, as I showed you earlier, there are some trials that looked at primary prevention. GLP-1 receptor agonists have a favorable safety profile and have been associated with with a significant weight loss. I mean, as we're talking about risk factor, weight loss is one of the major risk factors that can impact all cardiovascular outcomes, reduced blood pressure, diabetes, lipid, and so on. So that's another point or another angle that this medication has, and it's a huge issue independent of its effect on diabetes. The other class of drugs, the sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitor, is a fascinating class of drugs, and I think it has gone far more into the cardiology arena than the GLP-1 receptor agonist. As I said earlier, these medications were initially their work is mechanisms to block, because most of the glucose is reabsorbed in the proximal tubule. SGLT2 blocks the absorption. Therefore, you secrete you increase the urinary excretion of glucose, and with it you get a diuresis, natriuresis, a bit of reduction in A1C, weight loss, and systolic blood pressure reduction. So this is the scope is much larger than the GLP-1 receptor agonist. And again, we move from this basic mechanism that this drug was looked at 1960 to a huge impact on the cardiorenal benefit of these on the kidney, on the hemodynamic and the heart, metabolic effect, reducing systolic blood pressure, arterial stiffness. It's, again, we are learning as we do trials. I think we have to be humbled by these medications that is, again and again, is amazing to us, where every time you do a trial, you get surprised by the benefit, and subsequently, we are making some issues with the mechanism of them. So again, what triggered these is the cardiovascular outcome trial. And So again, we have three SGLT2 inhibitors: the empagliflozin, cana, and dapagliflozin. These trials were again done to assess the safety for these medication as an anti-diabetic class of medication. But then when the trial came out, again, you look at their baseline the kidney, it looks fine. Age is matching for a huge number, 17,000, 10,000, really quite an impressive trial. Again, patients who have prior heart failure, there's some. This is not intended to look at patients who have heart failure, but we know heart failure is heavily associated with diabetes. Prior cardiovascular disease, the EMPA-REG was heavily secondary prevention. CANA, half-half. DECLARE was more of a primary prevention. Again, looking at the 3-point MACE, cardiovascular death, all-cause mortality, the first thing you can see that they all impact heart failure, particularly here. Cardiovascular death or heart failure hospitalization, the three agents work very nicely. For EMPA, there's an added benefit of 3-point MACE, cardiovascular death, all-cause mortality, which is again significant. Surprisingly enough, and you will be surprised too, that dapagliflozin initially in this have one significance, and that's one of the secondary endpoints, the cardiovascular death or heart failure. There was no other vascular benefit on this medication. But again, trials surprise you sometimes. So from that, this is really as you can see, the 4 trials here, the Veritas, there's another gliflozin. All of them, EMPA has significance in the 3 parameters. CANA has MACE and heart failure, but all of them has significance in heart failure hospitalization item, which distinguishes this class of drugs from the GLP-1 receptor agonist. Now, cardiovascular benefit with or without heart failure, it's irrelevant. Now, this is one of the parameters, cardiovascular death and hospitalization for heart failure. And again, you look at the 3 trials here EMPA and CANA, but the pooling of this depth significance. Of course, if you have history of heart failure, the benefit is far more significant than just having it in the general population of the trial. Now, I think we have gone way beyond our understanding of these cardiovascular outcomes. SGLT2 inhibitor now have evolved in looking at all stages of heart failure with or without diabetes. And that was what I was talking about. I think what makes these agents have a global effect in patients when they have, we know that they may impact diabetes, but their impact will be far more if they are also work in patients who have no diabetes. Here, in type 2 diabetes patients, they have preclinical. Some of those patients may have heart failure. This medication prevented heart failure. And you have all these outcome trials that I've just talked about. We have 2 more trials looking at patients who are actually have heart failure through an acute phase of myocardial infarction. So in the clinical state of the disease, and that's IMPACT-MI, that would be empagliflozin and DAPA, and SCORED looked at those patients who have also chronic kidney disease, which is also published. So all these orange, these are published, and I will touch on them very quickly. The main impact now, we have these medications treat heart failure. And now they're considered as one of the major pillars in treating patients with heart failure, regardless whether they have diabetes or not. And that's primarily DAPA heart failure and EMPEROR-reduced, and recently SOLOIST, and that's looking at worsening heart failure. And there are 3 more studies looking at heart failure with preserved ejection fraction. So we have distinguished DAPA and EMPEROR looked at patients with reduced ejection fraction. And then we have the other item of heart failure that's preserved ejection fraction, which really encompasses a huge number of patients, diabetics, hypertensives, and so on. So the impact of this medication is significant. And I just said earlier, these are the 4 main medications that we use in heart failure now. And as you can see, SGLT2 inhibitor, DAPA and EMPA are there. And they are there because of the trials. This is DAPA heart failure looking at 4,744, ejection fraction less than 40. This is HFrEF, eGFR more than 30, randomization to a placebo, and placebo means other heart failure medication, and DAPA on top of the other medication, follow up for 8 months, highly significant, very early separation. I mean, really, you're talking about even the best cardiovascular medication that we have for heart failure. At 28 days, you have significance with dapagliflozin. You need to treat only 21 patients to save 1 life. That is a major impact. This is EMPEROR-reduced using empagliflozin, and again, around 3,700, EF less than 40, eGFR even lower. And I think, you need a whole hour to talk about the impact of this medication on the kidney. So EMPA 10 milligram and follow up for 16 months, again, highly significant, very early separation. Primary endpoints, cardiovascular death, heart failure hospitalization, urgent heart failure visit, and here you need to treat 19 patients. And if you, and as I said again, both trials have diabetic and non-diabetic. And as you can see here, looking at the diabetes status in these patients, and the with diabetes, you see how significant, way out from the line. And again, for the without diabetes, you have exactly the same benefit. So these drugs work independently of the diabetes status of the patient. This is a comparison. I don't think the main issue here now how do they compare to what we have in the treatment for heart failure that we deal with? Beta blocker, MRA, eplerenone. This is the newest that we have, sacubitril valsartan. It's called Entresto or ARNI, and these are the DAPA and EMPA. And as you can see, these are the number of patients you need to treat to save one life: 27 beta blocker, 19 MRA, 37. And look at this. These are the two SGLT2 inhibitor. I think this is a major breakthrough in the treatment of patients with heart failure. I want to touch very briefly on, this is a newer, it's called sotagliflozin. Now, you have to realize that SGLT2 is primarily in the kidney, but there's SGLT2 in the intestines. Now, EMPA and DAPA have minimal effect on the intestines. Sotagliflozin have a dual effect on the SGLT2 and SGLT2. And therefore, again, it looked at in another trial. I think it was stopped early. You have about 1,200 patient follow-up for 9 months. Again, for urgent, the admission was for urgent heart failure. So these patients were sick. And again, you can see adding sotagliflozin has a very important impact on the survival of those patients. This is the SCORE trial looking at patient who has, again, acute events, and yet also they have CKD. And as you can see, they have diabetes and CKD, EF 25 to 60, significant impact on the primary outcome. Of significance now, when they pooled these trials together and they looked at patients with ejection fraction, and they could separate 3 categories. Those patients who have EF less than 40, between 40 and 50, and above than 50. Now, this is a sub-study analysis, but it's a very important concept when we talk about the impact of these medications on the range of heart failure, on the spectrum of heart failure. Because heart failure, even though the word is unanimous for all, but the pathophysiology is completely different from HFrEF to HFpEF. The symptoms are, one, you have a very weak ventricle, the other one, you have a super stiff ventricle. So the impact is very, very important. Now, in patients with low ejection fraction, sotagliflozin has shown significant impact on those patients. In those in the mid-range, EF 40 to 50, less than 50, again, a very significant separation of the curve and a significant, but of really, really significance is this. Until now, most of the trials that looked at heart failure with preserved ejection fraction failed. We do not have one positive trial. And I tell you, when your patient has hypertension for a long time, and they come in with shortness of breath and pulmonary edema, and the ejection fraction is normal, what you need to do. So we are in desperate need to have an agent that can impact those patients and improve survival. And by the way, diabetics have the worst HFpEF. So that is a sub-study analysis, but there are 2 trials coming out, Emperor Preserved and the DAPA Preserved also. They are randomized to look prospectively at those patients. Yet again, the usage of these medication until 2017 was really, really disappointing. And particularly yesterday, I was talking to cardiologists about SGLT2 inhibitor. Well, the only thing that I can say that this is before these trials that I talked about. And I hope, I think for endocrinologists and cardiologists, and these 2 specialties work so well together, because as Dr. Khadija suggested, we deal with the complication of these patients. So there must be a definite collaboration between cardiologists and endocrinologists, and hopefully we can improve on the level of usage of these very important medications. And the guidelines said that. This is the latest, American College of Cardiology 2021 expert consensus on the latest on patient and the guideline, what to use in patient with heart failure. And as you can see, SGLT2 inhibitor is one of the main, actually, in other forms of SGLT2 in certain patients, particularly in diabetic patients, should be used as early as before RNE. And personally, for me, it's beta blocker and SGLT2 inhibitor. And then you can add on. But of course, there's multiple variation to what you use depending on the hemodynamic status of the patient, which is very important to watch for blood pressure, volume status, diuretics, potassium. So it's a huge issue, but I think this is such an easy, simple drug to use and titrate. You don't need titration. It's one dose. And the effect on blood pressure and the diuretics is very mild, yet you get such an amazing benefit. And the ADA standard of care 2021, of course, they still, for first-line therapy as metformin, but there is no doubt that independent of baseline A1C, if somebody has established cardiovascular disease, you need to start initial GLP-1 or SGLT2 inhibitor. They have the vascular benefit. Heart failure, a must. SGLT2 should be number one. And if you have CKD, again, SGLT2 showed significant benefit on renal function, and otherwise you can do the GLP-1. So I think beyond diabetes, beyond heart failure, these two agents are one of the most important pharmacological pillars of cardiovascular protection. And patients with diabetes, they need these interventions much more than any of the patients that we deal with. And I think the previous speaker has made it absolutely clear on the risk. We treat triglyceride, blood pressure, LDL, and so on. Thank you very much for your attention. I'll be happy to take any question at the end. Thank you very much.
Thank you very much, Dr. Tamimi, for this excellent, comprehensive talk. And I just want to remind again the audience, we have above 460. So kindly, type your questions. If you have any question in the Q&A box, I can see there are many great questions. So please keep these coming. And now we're going to have an interesting interaction case discussion on the high-risk case and the newly diagnosed diabetic in the clinic. It will be shared by both Dr. Khadija, who I already introduced, and Dr. Hani Sabur, who by now you already know. He's a consultant cardiologist and electrophysiology at Cleveland Clinic, Abu Dhabi. So the floor is yours. Please, both of the speaker, proceed.
Assalamu alaikum. Thank you, Dr. Fatia, once again. In order for us to illustrate how we can incorporate the knowledge that we've learned from the clinical trials, as so elegantly described by Dr. Al-Tamimi, and the guidelines, we thought we'd put up a case so that we can share that experience and see how we can actually use that in our clinical practice. So the next slide, I think, is going to show our disclosures for both myself and Dr. Hani. And the case then is a patient that was in the coronary care unit. This is Khalid. He's a young man, aged 53. He's a heavy smoker. He's got a family history of type 2 diabetes. He's obese. You can see his BMI was 30.3, and he presented with chest pain and was diagnosed with an acute coronary syndrome. So at the time when we were asked to see him, he was already on a dual antiplatelet, he was on a beta blocker, he was on an ACE inhibitor, and he was on a high intensity statin. So I'll show you his ECG and let Dr. Hani tell you more about it.
So I hope I can get this one right. So what we see here is, of course, sinus rhythm, and we have massive ST elevation. So you can clearly see already the evolution of a Q wave in V1 and V2, and there's at least 7 millimeter ST elevation extending from V1 all the way to V6. You can also see some subtle ST elevation in AVL. This is a very large anterior, septal, and lateral myocardial infarction. There are some reciprocal changes inferiorly, probably indicating a huge wraparound LAD with a very proximal takeoff. And you see also this PVC here. This is kind of an ominous sign. You have a PVC that's coming from the infarct area. It's coming almost on the T wave. So this is the kind of ST elevation MI that's going to cause massive LV dysfunction if not dealt with immediately.
Okay, so we had some more sort of history around the patient. We know that he's a bus driver. And then we had his lipid profile. He has an LDL of 109 at baseline with an HDL of 35, which we all agree is quite low. Triglycerides were 168 milligrams per deciliter. His blood pressure was recorded at 146 over 77 millimeters of mercury. An echocardiogram was also done, and his ejection fraction was found to be 55%. In addition to that, we also have his kidney function. So he's got a good eGFR at 82 mils per minute, and he doesn't have microalbuminuria. So this was the consult from the diabetologist. Lucky for him, he was in a unit whereby they were following protocols. They did the hemoglobin A1C, was 8.9%. So we were summoned to kind of treat his glycemia. And, you know, the question is, how are we going to try and manage his cardiovascular risk, considering his new diagnosis of diabetes? And what is important to underlie here is the fact that we've had a missed opportunity for an earlier diagnosis. He is a gentleman who's got class 1 obesity, he's got a positive family history of diabetes, and he's also got hypertension. And he's having a diagnosis of diabetes at the time when he's actually presenting with an acute cardiovascular event. So we would like to have a polling question now, and we would like you to answer the following. When would you have considered screening Khalid? So would it be at the age of 50 and above? Would you consider it at any age in a person who's overweight or obese with an additional risk factor? Do we screen only symptomatic individuals? Do we screen only those with a positive family history of diabetes? Or should we only screen males that are above the age of 40? So if you can take a few minutes to read that and answer the poll, we'd be very happy if you did so. Okay, so the polling is closed, and I'm glad that everybody was paying attention to the earlier talk, and I can see overwhelmingly that people have chose option B, which is absolutely correct. So we do and should screen all adults at any age who are overweight or obese who have an additional risk factor. So and that is underlined in our guidelines, and I showed this you earlier in my earlier presentation. But what I would now like to reiterate again is the additional risk factors. So what are these additional risk factors that we want to be considering? So next slide, Dr. Hani, please. So the additional risk factors, whether the patient is in the clinic, an inpatient or outpatient clinic, or is admitted to a hospital, we should be thinking about screening if they've got a first-degree relative with diabetes, if they've got evidence of pre-diabetes on previous testing, if they've got lower levels of HDL, evidence of dyslipidemia, they're hypertensive, they've got physical inactivity, or belong to a high risk ethnic groups. So these are sort of the traditional risk factors. Perhaps Dr. Hani would like to elaborate more on the history of cardiovascular disease.
So I think it's kind of a shame that this patient was diagnosed with diabetes only when he had acute coronary syndrome. And I think as a cardiologist, it's become an important clinical point that any patient that I see, whether they have an ACS, an MI, a stroke, heart failure, atrial fibrillation, all of this belies the metabolic syndrome, and therefore screening for diabetes on an opportunistic basis and for clinical reasons is very important. So any cardiovascular disease patient coming to any cardiologist for any reason, frankly, should have screening for diabetes.
So we were able to get some more detailed history on this patient, and then on further questioning, he did give a history of shortness of breath and exertion that had been present for the last 6 months. He did have fatigue and polyuria for almost a year, but he thought that that's just normal and related to his age. He did also mentioned that he was having some epigastric discomfort, especially during the night, which he attributed it to gas. He does have a sedentary lifestyle. He does a 12-hour shift driving the public municipality buses, and he just gets 1 hour lunch break. And you can imagine what his lunch is. He was found to have high blood pressure 2 years ago, but he wasn't convinced at starting treatment. And there again was a missed opportunity for him to have been screened for diabetes. The other thing that we also found interesting is the fact that he was noted to be snoring quite loudly whilst on the ward, and the nurses did mention that his oxygen sats dropped to about 90% when he was sleeping. So to summarize his case, then, Dr. Hani, what do you think about these other sort of risk factors or other salient features that are coming about?
So this is essentially staring in the face, right? I mean, all of the features of metabolic syndrome were there to be had. The presence of, as you mentioned, risk factors and obesity, and of course the connection between sleep apnea, insulin resistance, and metabolic syndrome are a clue regardless. And the screening for diabetes may have led to more intensification of therapy, more lipid lowering, possibly even a search for an abnormal ECG. The treatment for hypertension may have prevented this event. So this is really all events linked to a metabolic abnormality and that could have prevented a cardiovascular event. But enough said, I think it's a little bit too late. So unfortunately, we've actually had to diagnose diabetes and CVD at the time of the event rather than both. And we're actually dealing with complications of diabetes in the form of cardiovascular disease at the same time in a very dramatic way. I think the whole point of this is that there's early opportunities for intervention that could have well prevented this patient having an acute event.
Yep, absolutely agree. And so just to summarize our patient, he's sustained and succumbed to a myocardial infarction. Fortunately for him, his ejection fraction is still preserved. He's got evidence of class 1 obesity. He's got a new diagnosis of diabetes with really a poor hemoglobin A1C. He's got normal kidney function. And we think he might also have underlying obstructive sleep apnea. So that's something that we would want to address as well. So in thinking about his management, and this is a management checklist that we all should have in our cardiometabolic clinics, thinking about the ABCs of management. So we're not just, and we need to be doing this simultaneously, thinking about the glycemic control, making sure he's at his blood pressure target, he's on drugs that are going to protect his heart. We're going to have to put him on an exercise regimen and change his diet drastically. He is a smoker, so we're going to have to address that as well. And of course, we're going to have to address his lipid profile. And I'm just wondering, Dr. Hani, what do you think about these ambitious targets of getting, patients LDL more than 50% of their baseline? Are we achieving this in clinical practice?
So, in fact, it's well seen in big registries from Europe and from our region and from the United States that fully 70% of secondary prevention patients and at least 50% of primary prevention patients, which includes diabetes, which is the highest risk in that, are not achieving these LDL targets. So the European guidelines have a dual target, which is a 50% reduction from baseline, and for the diabetes with risk factors, 1.4 or 55. And for a patient who just has diabetes with no additional risk factors, 50% and 1.8. So I think even this 2 millimole is probably not consistent with the current guidelines. And unfortunately, even with the less rigorous guidelines, we're not actually reaching that number. So there's a lot to be said about the background therapies in diabetes that need to be optimized as well. And it might be a good point to actually ask ourselves, why is this happening? I mean, we have so many tools, and these are all very easy lab tests and physical markers that everybody can address, at any level.
Yeah, and so the focus really should be on a comprehensive cardiovascular, risk reduction. So we've already addressed the issue of screening early with and those at high risk for cardiovascular disease, aggressively treating those risk factors, and then incorporating these newer glucose-lowering agents that have evidence of improving cardiovascular outcomes, as Dr. Tamimi has taken us through with all the cardiovascular outcome trials. And the question is always that, who should be the one to write that prescription? Should it be the diabetologist, the endocrinologist, the cardiologist, the nephrologist? Who has the upper hand? What do you think, Dr. Hani?
Well, why not the first person to see the patient and identify the risk, pull the trigger? Because obviously these are time-dependent interventions. And as we saw with our unfortunate patient, he had about a year's worth of, diabetes-like symptoms and multiple risk factors. So, I think the first person who puts his hand on a patient like that really should consider what's the underlying risk and why not start the medications as soon as possible. Now, with that being said, I think endocrinologists have had a tremendous experience in the utilization of these agents. And I think it's all very valuable for us to have these learnings together. What are the side effects? What are the benefits? What are the indications? When to start, when to stop, how to manage.
Okay, so we see that there's really a dramatic change in our treatment paradigms. One, in that glucose lowering is not just the domain of a diabetologist and an endocrinologist, but we're encouraging that cardiologists as well should be able to offer patients, glucose lowering agents that have cardiovascular and renal benefits. And then when we come to now thinking about what are we going to give this unfortunate young man, who's just been diagnosed with diabetes and has had a cardiovascular event, we have 5 basic, categories to choose from. We have the GLP-1 receptor agonist and the SGLT2 inhibitors that Dr. Tamimi has already talked about the mechanisms of action. The other anti-glycemic agents available to us, of course, are metformin, the TZDs, and the DPP-4 inhibitors. And just a reminder to the cardiologists, if you're out there, the DPP-4 inhibitors are also incretin-based therapies, but they have not been shown to have any added cardiovascular benefits. So they're cardiovascular safe. They can be used for glycemic control, but they don't give you any additional benefit in terms of cardiac and renal protection. So the other thing that I find quite interesting in the treatment paradigm is the fact that the guidelines are now more homogeneous and more harmonized. But before I go to the guidelines, let's look at what agent do we think we might give Khalid. So again, another polling question. Do you think we should start him off on an SGLT2 inhibitor? Should we start him on metformin? Should we start him on a GLP-1 receptor agonist? Should we start him on a sulfonylurea? Or should we start him on a combination of metformin and a DPP-4 inhibitor? So we'd again like you to cast your vote, and then we'll discuss the options.
I think what might also make a difference to the audience is the concept of newly diagnosed in the setting of an acute coronary syndrome.
Absolutely.
sort of the highest of the high-risk patients.
Yeah. Okay, so that's quite interesting. We've got 40% who've opted for the SGLT2 inhibitor, and 28% have opted for the GLP-1 receptor agonist. I'm quite happy that nobody, or just maybe 1%, one person has opted for an SU. So what do you think about this, Dr. Hani?
So this is very interesting. I think in a patient with a recent acute coronary syndrome, you know, the clock is ticking and there's a lot of evidence here, but I think if we look at the SGLT2 inhibitor trials, they did not enroll patients with an acute coronary syndrome. They enrolled patients with established ASCVD. Isn't that right?
That's correct.
And now that's not to say that they can't be used. Similarly, almost all of these other agents have been used in sort of the outpatient setting. So I think we have to think about early utilization. I would be very interested in the use of a GLP-1 receptor agonist because of its profound effects on atherosclerotic events, as Dr. Hassan very nicely showed us, and its impact on vascular issues as well. The SGLT2 inhibitor would be of interest in a patient with more of a renal component or a heart failure phenotype as well.
Okay.
I would obviously, I agree with everyone who did not start the patient on a sulfonylurea.
Right. Yeah, okay. And so the other change in the treatment paradigm is actually the fact that we've got this harmonization of the guidelines. So whether you're looking at the cardiology guidelines or whether you're looking at the diabetes guidelines, they've all got this unanimous agreement that for those patients that are at a high cardiovascular risk, the recommendations should be to initiate either a GLP-1 receptor agonist or an SGLT2 inhibitor. And as we've seen now, that should be regardless of what the baseline hemoglobin A1C is and whether the patient had been on metformin or is really drug naive. So these are the European and the cardiology guidelines. Let's look at what our own local guidelines say. And therefore, I'll take you back again to the slide that I showed you earlier on the cardiovascular risk. And we've really highlighted for this particular gentleman, he's got type 2 diabetes. He's got a cardiovascular event, and therefore he really is at a very, very, very high risk. And I couldn't, emphasize that more. What do you think, Dr. Hani?
So, of course, diabetic patients with 2 risk factors or more are considered very high risk. But within that very high risk, there's people who are, I think, which was called by the ACE guidelines, extreme high risk, right? And while that applies to lipids, it also applies, it's the same patient, it applies to their diabetes and metabolic profiling. So the National Lipid Association, oddly, has actually given this number, a 40% risk of fatal or non-fatal events within the next 10 years. So that's almost double the high risk definition, very high risk definition of ACC. So even within high risk, there's higher risk. And of course, an early, within the first 12 months of acute coronary syndrome, the recurrence rate and mortality is very high. So I think there's an urgency to act quickly and act comprehensively, because it isn't just stable target organ damage. There's a likelihood of a recurrent event as well, which could be fatal. Obviously the patient was saved by our brilliant interventional cardiologists.
Right, so here again, we're thinking about this patient is definitely in the very high risk category. And we know that the risk of a recurrent MI is highest in the first 12 months after the first event. And therefore, should we be adding the SGLT2 inhibitor and the GLP-1 receptor agonist simultaneously? Here we need to be thinking about, this is a patient who's just been given a diagnosis, 1 of a heart attack and 2 of diabetes. Psychologically, would it be easy to convince a patient in such a situation to accept an injectable therapy as well? Because Now, this is a gentleman that we're going to have to counsel not only about giving up his smoking habit, he's got to change his dietary habits as well. He's going to go home on quite a lot of medications. You know, he's going to be on antiplatelets, he's going to be on a statin, he's going to have to be on a beta blocker as well, blood pressure medication. So what we did, and what I would, my approach for such a patient is choose the SGLT2 inhibitor and metformin together. I would combine those together because he's starting off with a very high hemoglobin A1C. And then when I see him in the clinic a few weeks later on, introduce the idea of a GLP-1 receptor agonist, because I know he's also got obesity, and the GLP-1 receptor agonist would help to kind of lower his weight further. Now, if we were to combine the two, the SGLT2 inhibitor and the GLP-1 receptor agonist, we can do that. We know for sure that that helps to optimize the glycemic control, but from the trials, we don't know whether that has an additive effect in reducing the cardiovascular burden. So our approach for this patient was start him on metformin with the SGLT2 inhibitor simultaneously. The other reason that we sort of shied away from introducing the GLP-1 receptor agonist that early was, what if he had developed some sort of nausea or just, the GI side effects related to the GLP-1 receptor agonist? It would be very difficult to tell whether is it just the drug causing the nausea, or is he having another event? And therefore, it might be wise, or you could add them. I'm not saying that you can't, but the approach that we took was give him the SGLT2 inhibitor and metformin, and then definitely have the conversation with him about your GLP-1 receptor agonist in the clinic as early as possible. Any other thoughts about that, Dr. Hani?
No, that's a brilliant approach. I mean, again, patients are not textbooks, neither are their clinical studies. So we have to study our patient and understand how this is going to impact their acceptance. And you don't want them to get a side effect which prevents them from using it later on. But at the same time, this guy's main presenting symptom was epigastric pain, as you very wisely pointed out. So we'd then be going around in a circle. Is the epigastric pain from his coronary artery disease, or is it from the medication? So I think it's reasonable to do stepwise. But what I would ask is, would you see the patient in 3 months in the traditional diabetes clinic, or in the cardiometabolic clinic? Would we do it a little bit earlier? So right. I think maybe we're going to answer that later on.
Later on, yeah, sure. So now we put a little bit of twist in Khalid's case, and we're thinking about, what if he had an ejection fraction that was less than 40%? Would our choices be different? How would you approach it now, Dr. Hani? If, say his when we did his echo, his ejection fraction was 55, but what if it was less than 40?
Sure.
What would be your preferred agent?
So as you have pointed out very nicely, and Dr. Hassan has also enlightened us, in patients with LV dysfunction, these are the patients that derive the most unique benefit of the SGLT2 inhibitors, and that is prevention of heart failure, and now the utilization in treatment of actual heart failure with reduced ejection fraction. So the concept here is that you would start the SGLT2 inhibitor early, because now this patient has the heart failure phenotype, not just the ischemic phenotype. So he actually has 2 in 1. And the idea is to reduce hospitalization for heart failure. And of course, since the guideline was written, concurrently with the release of some of the clinical studies, reduction of cardiovascular death and combined endpoint. Now, the additional point here, of course, if the patient's GFR was lower, monitoring the kidney function. But one of the things that I've learned from you as an endocrinologist and my other colleagues at Imperial Diabetes Center is that when the kidney function is lower, it doesn't attenuate the life-saving effects of the drug on the heart or the kidney, but the glycemic impact is reduced, because in the end, it actually works by excreting glucose in the urine and sodium. So you may actually need an additional glucose-lowering agent if that's the only drug you're using. So that's really why a combination with another agent would be recommended. Would that make reasonable sense to you?
Absolutely, absolutely agree. So again, if the patient were to have renal impairment, the SGLT2 inhibitors are still working to protect the kidneys, and they still have the cardioprotective effects. It's just that this glycemic efficacy is then much lower. And in which case, if the patient's hemoglobin A1C is still high, because it is important to get that hemoglobin A1C low, because we stress on the cardiovascular risk reduction, but we mustn't forget that these patients can have microvascular events as well, and therefore we do want to get the hemoglobin A1C down, and therefore you would need to use additional agents as well. So we've kind of addressed the issue of the lower eGFR, but what if the eGFR drops while he's on treatment? What would you do in that situation?
So this is very interesting, and I think it's very important for both of us to highlight to our colleagues is that these are not nephrotoxic drugs by any means. In fact, if anything, we've seen in the heart failure studies and in the primary prevention studies a remarkable prevention of decline of renal function, a remarkable reduction of microalbuminuria, a remarkable reduction for the need of end-stage kidney disease and dialysis. So when there is a transient drop in GFR, that's exactly what you expect. That's exactly the phenomenon that tells you that this is working. This is the reduction of renal hyperfiltration and restoration of tubulo-glomerular feedback. And then we see that also with RAS blockers in the early stage. So that transient drop, don't panic, because within a few weeks, it's going to go back to normal.
Yeah, absolutely agree. And the other thing to add to that would be if the eGFR is less than 30, then perhaps the GLP-1 receptor agonist would be a better choice than the SGLT2 inhibitor. But as you've mentioned, if the patient was on it, you wouldn't want to stop it, because we've already seen evidence from DAPA-CKD and Emperor reduce that, even at lower eGFRs, patients are still able to get benefit from these agents. Perhaps then we might look at some sort of other practical tips and points on the use of these agents. So I'd like to turn your attention on fluid management, because we've got to remember that these agents do have a loop diuretic effect, and that might lead to an element of dehydration, particularly in patients that are more vulnerable. And this would include patients that are older, frail, they've got renal impairment, they've already got low systolic blood pressure, those that are on very high doses of diuretics, perhaps also on ACE inhibitors and the angiotensin receptor blockers. Dehydration is also a risk factor we've seen for amputation and DKA, and I'll talk about that. So in the guidelines, of course, the labels that we have for these agents is not to use them when the eGFR is less than 45, but as we've already mentioned, that the DAPA-CKD and the Emperor Reduce really did go down to eGFRs of 30 and below, and they were still found to be highly renal protective. So these are agents that you might want to temporarily discontinue, say in an inpatient setting where the patient has come in with vomiting, diarrhea. And then the other thing we want to think about is DKA, so diabetic ketoacidosis, and the risk for euglycemic ketoacidosis. So here is, you've got normal blood sugar levels, but if the patient has nausea, vomiting, and they've got fatigue and malaise, do check the ketone levels, because these drugs increase your glucagon levels, and therefore you might have near normal blood glucose levels and still be acidotic. We've also seen it happen in patients who go on ketogenic diets. They take very low carb diets or excess alcohol. That might also be a trigger for developing diabetic ketoacidosis. So we always say you need to stop temporarily an SGLT2 inhibitor for patients that are acutely admitted into the hospital on the ICU, those that are going to be kept, for surgery, NPO status, prolonged fasting, any planned surgery where it's, going to be metabolically stressful. You need to back off with these agents and then restart them when the patient's hydration status has been reestablished. Fournier's gangrene is a rare event, but it's something that we might have to mention as well. There were a few cases that were reported, and therefore, if the patient presents with any pain, tenderness, any swelling in the genital area, please take that seriously and treat them promptly and stop the agent. I must stress again that this is an extremely rare event. What about the concerns about amputations and peripheral artery disease? We know that the GLP-1 receptor agonists have very good evidence in patients with peripheral arterial disease. The results that we've had from Credence and Declare have actually mitigated and removed this doubt that we had about lower extremity amputations. We've seen that it wasn't significantly increased in this general cohort. And in fact, the black box warning that was initially present for canagliflozin, one of the SGLT2 inhibitors, has actually also already been removed after we had the results of the Credence trial. So one wouldn't hesitate to start these agents because of thinking about lower extremity amputations, but you might want to think and use them more cautiously if the patient has an active foot ulcer, for instance, or is actively being treated for their peripheral artery disease. You might want to use other glucose-lowering agents. The GLP-1 receptor agonist there would be a good alternative while the patient, is recovering sort of from their peripheral arterial disease. Any other thoughts, Dr. Hani?
No, I think that was very well said. I think, we have choices in terms of the treatment. So again, in the atherosclerotic field, and especially with peripheral artery disease, sub-analyses from the LEADER study suggested reduction of cardiovascular death in peripheral artery disease patients even more substantial than cardiovascular disease itself. And we know this even from the statin studies. Patients with PAD have almost 2 times the risk of cardiovascular death as an equivalent patient with cardiovascular disease as well. So, this might be a reasonable choice if your patient has leg ulcers and you have foot pulses that are reduced, or peripheral artery disease. A GLP-1 would probably have, at least in my mind, a higher preference in terms of the benefit.
Sure. And then, of course, we come to the managing nausea and vomiting for the GLP-1 receptor agonist. That is a reality, and we have to explain that to our patients. It is the most common side effects of these agents, but reassuringly, and we can tell that to our patients, that it's usually quite transient and self-limiting. And the way to minimize the nausea is actually to encourage the patients to eat slowly and take smaller meals, and that will greatly reduce the sensation of nausea. So we've chosen the agent of choice for Khalid, and now we are thinking about sending him home, and when would we want to see him in the cardiometabolic clinic? So should we call him within 1 or 2 weeks? Should we ask him to come in 4 to 6 weeks? Should he come at 3 months? Should we see him in 6 months? Or should we say, all right, we'll see you in a year? So again, we'd like to see what the audience think. When would you like to see Khalid in your clinic? Okay, so that's quite interesting. Majority have chosen for the 4 to 6 weeks. The earlier, the better. What do you think, Dr. Hani? How should we approach this?
So from a cardiometabolic perspective, we're not just looking at the routine every 3 months A1C type patient, right? This is a patient that we are actively engaging both psychologically and pharmacologically. And in fact, it might be even more appropriate to see the patient even earlier, because remember, it's a post-PCI patient, and you want to make sure there's no ischemic component as well. But I would say that in our practice, we would see the patient no further than 4 weeks, and we try to get them in during the motivation phase earlier than that. Is that something that can be done in this kind of scenario?
I would totally agree. And in fact, if you're setting up a cardiometabolic clinic, that would be an appropriate time frame. Remember, we also said we wanted to check about side effects from all the medications that we've sent him home with. So to check on compliance, to check on side effects, to think about optimizing, his glucose control. And I find that usually when patients have had an event, the earlier you see them, they're more motivated, psychologically, they're more prepared to take on the advice that you give them, that if you say, right, come after 3 months, they're likely to kind of relapse into their old habits. And so the things that you started on when the patient was in hospital might be lost if you're going to see them at a longer time frame.
Totally agree. If we're not excited about the follow-up, then the patient's going to be even less worried about it. So I think
right.
that's insert that into the head.
Okay. And so then what are the sort of things that we would want to actually follow up? So in the clinic, what we would like to optimize is, of course, biomarkers. So heart rate, their blood pressure. We want to look at the weight, their BMI and waist circumference. Very important, and we highlighted that in the last series of webinars as well, the pedal pulses, ankle brachial index. You would like to repeat the ECG and see if there are any other dynamic changes. Look at his functional capacity and edema. We want to assess the EGFR, and if the microalbumin wasn't done earlier, it should be done at this point, because this is quite important in that it's not just a marker of disease severity, but it's also a predictor for future cardiovascular events. We've stressed on the lipids as well, and maybe later on Dr. Hani will elaborate on the non-HDL cholesterol also, and the other lipid parameters. But as a diabetologist, I'm thinking about the pro-BNP, and perhaps this is something new for us. We're not doing it routinely. It's probably done in the cardiology clinics more commonly. What do you think, Dr. Hani? What is the situation with a pro-BNP?
So I think it's going to make its foray into primary care very quickly. In fact, the European Society of Cardiology in 2019 has recommended that general practitioners and diabetologists, essentially anybody who deals with diabetes, who has a symptom or an ischemia or an abnormal ECG, the NT-proBNP immediately stratifies the patient into having also heart failure in addition to ischemia, or heart failure in addition to diabetes. And it's very powerful because it predicts mortality. And if it's abnormal, it tells you that the patient has heart failure, so it'll trigger a heart failure evaluation, including an echo, but it should also trigger the addition of heart failure medical therapies, such as SGLT2 inhibitors and RAS blockers and so on. So simply from this test, you can go on very accurately and rigorously to treating one of the lesser recognized but just as serious complications of heart failure. So I think the guidelines have espoused this. We have to sort of become more cognizant in its use and its relevance, very strong relevance in clinical practice.
Okay, great. So what else can be done to reduce the cardiovascular risk in the long term? So we know that lifestyle modification, comprehensive intervention with evidence-based medical interventions that are highly effective in the post-MI patient, and therefore cardiac rehab with outpatient visits, maybe 3 sessions of 60 minutes weekly, incorporating the dietary counseling as well, focusing on lipid and glucose control, weight loss. And for this particular patient, because he was a heavy smoker, making sure that he goes into a structured smoking cessation clinic as well. And what else can we do? And perhaps you might want to elaborate on other steps as well, Dr. Hani?
Sure. So the physical component is also very important, but it's actually been shown from many clinical studies of cardiac rehabilitation. It actually reduces cardiovascular events. And it's funny, it's not because of the exercise, it's because of the training and the cohort that the patient is actually enrolled in, right? It's a cohort of like-minded people who've had a heart attack, had a stroke, had a bypass, and they share their experience and they gain from each other, and there's classes. So it's actually very empowering, and physically as well as in a different psychological scenario. And of course, we insert these classes on top of the cardiac rehab so that we motivate the patients towards a healthy lifestyle, towards smoking cessation, towards diabetes control, towards checking their sugar. So it's very powerful and actually can reduce cardiovascular events by 15%, mostly through driving compliance. Now, the other important points are, of course, as physicians, we want to have risk assessment and optimization. So it's very important, as you mentioned, to do this on a routine basis early and have these discussions essentially ongoing. So as you very nicely pointed out, at the first visit, I think further discussions on adding on the GLP-1 receptor agonist. How would we approach this? So we would highlight the positive, the weight loss, the cardiovascular protection. I mean, this is a very significant impact if we look at the data from LEADER in particular. And rewind. Highlighting is also improving A1C control, highlighting the weight loss. And of course, now the patient has choices, right? So you have the compliance with once weekly GLP-1 receptor agonist, a CV benefit. You have the daily GLP-1 receptor agonist with CV benefit. So there has to be some preference involved. The other point that's really critical in the early phase is maintenance of combination high-intensity statin and ezetimibe. This patient, as maybe some of you recall, had an LDL of 109. So what is this patient's LDL target? It's 50% of 109 and reaching less than 55. This is very difficult to achieve with a high-intensity statin. 50% is the definition of a high-intensity statin. But with this patient, it may not bring this patient down to LDL of 55, which is non-negotiable. I think we have to agree that we can't negotiate the guidelines or the targets with the patient. So this is a patient who may actually need high-intensity statin and early addition of ezetimibe. And if they still don't achieve their LDL target, this is a legitimate patient to get them down within 4 to 6 weeks with a PCSK9 inhibitor or inclisiran. And the guidelines are also very explicit. Once you make a change in a high-risk patient, you should check the LDL again in 4 to 6 weeks, not 3 months, not 6 months, not annually. So this is a big miss on the part of a secondary prevention patient. And I just highlighted this for everyone. It's a mandatory 50% reduction and also LDL less than 1.4 or 55. And if a patient has recurrent cardiovascular events like a heart attack or a stroke within 2 years or a heart attack and another heart attack, 1.0 is required. Now, one of the points that Dr. Khadija mentioned very nicely is that there's going to be polypharmacy. And polypharmacy here is by necessity. Oftentimes, polypharmacy has a negative connotation, but here, polypharmacy is life-saving. As Dr. Hassan showed us, it's very important in these patients. You have to manage complex cardiac, vascular, and metabolic problems with evidence-based medicine almost simultaneously. So the discussion of the side effects is probably one of the most important ways to avoid interruption of life-saving medications. And you know that the commonest side effects of statins are going to be some muscle symptom that may or may not be connected, and of the GLP-1 is some mild GI side effect that may be easily managed. So I think that's the role of this clinic, looking at these targets aggressively and early, and then asking the patients preemptively even, are you having this side effect? Are you having that? And have you stopped your medication? So Dr. Khadija, I'm just going to add a few things that we think about as cardiologists on sort of a more routine basis. And I think the heart rate is one of these missed opportunities. So we've known for decades that an elevated heart rate, regardless of your cardiovascular problem, be it AFib, heart failure, coronary artery disease, or even hypertension, reflects sympathetic overactivation. And this noradrenergic drive is always adverse, and particularly so in the post-MI patient and the heart failure patient. So always got to check the pulse. And I've actually seen this pattern where the nurse is giving you the blood pressure, but not the pulse. That's really kind of upside down, because that's the simplest vital sign that we can address, and the most robust treatment we have for that is beta blockers. Now, I think, yes, go ahead.
Yes. Yeah, so the other thing is also that's very important. And the other, because they are being seen in the cardiometabolic clinic, and there may be an endocrinologist and a diabetologist running that clinic. The other thing is about the duration of the dual antiplatelet therapy. So what sort of approach should we take with regards the use of antiplatelet therapies?
Of course. So this is a key point again. This is one of the things that we have to define at the time of discharge with the discussion with the interventional cardiologist. It's a critical planning point. And in fact, it can be very confusing even for the cardiology team. So In a post-ACS STEMI patient, the data is fairly robust that 12 months of dual antiplatelet therapy, whether it's aspirin and clopidogrel or aspirin and ticagrelor, is essential. This is really how you prevent early stent thrombosis and early cardiovascular events. However, for an elective PCI, the duration is variable and depends on many factors: number of stents, what we call the ischemic risk score, if there's non-revascularized territories, the length of the stent, whether it's drug-eluting. If it's the modern drug-eluting stent, sometimes even 3 months is enough. If it's the older generation, 6 months is recommended by the manufacturer. So there's a lot of detail to this decision. And I think what we do is when we discharge the patient, the interventional cardiologist puts in their cath report, I'm recommending DAPT for this amount of time for this reason, right? So nobody has any confusion, because the worst thing you could do is prematurely stop the DAPT and the patient gets a stent thrombosis. It's almost like going backwards. And these are very difficult to manage. The other important point is what's called extended DAPT. So there was a study called the Pegasus study, and an older study, much older, called the Capri study from the 1990s, that showed in patients with high ischemic risk and low bleeding risk, you could go on longer with lower doses of the antiplatelet therapy and actually reduce cardiovascular events at the cost of some slightly increased bleeding risk. So this is an individual decision that really has to be very formalized and put very clearly in the electronic medical record, and probably the patient has to know it as well.
Right. Yeah. So, and then last is to be thinking about also the concepts around weight and sleep apnea, because we know that with weight reduction, it may also help with the blood pressure reduction. It may also have an impact on the incidence of atrial fibrillation. So referral for sleep apnea evaluation and CPAP titration may also be quite important. And then we've talked about also using the ProBNP and your echo to evaluate the left ventricular ejection fraction for recovery and remodeling, and use of other beneficial agents that can further modulate that risk. What are the other things that are on the horizon? After we've looked at all these sort of traditional risk factors, is there anything else that we might be able to do for our patients?
Thank you, Dr. Khadija. So this is what is termed generally residual risk. So in statistical studies, that is the percentage of patients who have a myocardial infarction in spite of aggressive LDL lowering. And of course, in spite of now glycemic control with a GLP-1 receptor agonist. You can't really drive it to zero. So people are thinking about these things, and they have now very powerful randomized clinical studies, which I anticipate are going to be given very high levels of evidence in the guidelines. However, I still have to go back and state from the most recent registries done here, the CTS Gulf study and the DICES-2 studies, we are still not achieving LDL goals. So these are to be done after we have achieved LDL targets, right? So once our LDL is squarely at 1.4, which is difficult, then we start chasing these other approaches. So in order of nothing really in terms of sequence, so low-dose colchicine has now been proven in post-MI patients from the Colocote and Lodoco studies to actually reduce recurrent events through an anti-inflammatory mechanism and reduction of CRP. Triglycerides, we have the immediate effect, the post-MI, the old GISI prevention study, which used 1 gram of omega-3 EPA-DHA to reduce myocardial sudden death. Then the more recent study reduced it. It's a remarkable clinical study, 25% reduction of myocardial infarction with high-dose icosapent ethyl, again on top of high-intensity statin with LDL lowering. And now some additional approaches, including anti-thrombotic approaches. So we have what's called the COMPASS study. So at the time of your dual antiplatelet therapy is going to stop at 12 months. We're not going to be cheering the loss of clopidogrel. I think now there's a study that says at 12 months, you have a very powerful advantage by adding low-dose rivaroxaban, 2.5, which is the vascular dose, to aspirin, because that lowers cardiovascular events, including stroke, by almost 45%. So it's not like waiting for the clopidogrel to go away. Now we have an alternative. And there's also an alternative approach, which is the low-dose ticagrelor, which is a 60 milligram from the Pegasus study, twice a day, again, long-term. This is all designed to reduce the risk of recurrent cardiovascular events on top of maximum intensity lipid lowering therapy.
Okay, Great. So I hope we've been able to convince the audience that when we're managing patients with type 2 diabetes, we really need to think about cardiovascular prevention. And in order to do that, the treatment is actually driven, the strategy is driven mainly by the treatment regimen more than the hemoglobin A1C reduction. Whereas when we're thinking about prevention of microvascular complication, it's driven mainly by A1C reduction, regardless of the treatment regimen. I like this concept of the CKD. So we really need to work together. That is the new paradigm, the cardiologist, the nephrologist, and the diabetologist, in order that we can work together in this sort of new paradigm of a cardiometabolic clinic. It offers us this very powerful educational, psychological, and motivational support within the clinic, where we can actually offer the patients a holistic and multidisciplinary practice model.
The objective, of course, would be a comprehensive and long-term sustainable pharmacological and behavioral risk reduction for both metabolic, cardiac, and renal, as well as physical complication of both disease spectrums on both ends.
And so it really is time and resource intensive, but it's well worth the effort in saving lives and restoring well-being and personal rehabilitation and recovery of a productivity and a normal life. So as we've seen, we've got the guidelines, we've got the means. All that's left is the will to do it.
So again, this is the big question we're going to ask to our 493 attendees and ourselves on a daily basis. Why are we waiting? There is no time to lose for our patients with diabetes and coronary artery disease. There are opportunities at every stage to detect this, to prevent it, to treat its complication. And I borrowed this slide from our dear friend, Professor John McMurray, the empty chairs in the cardiology and diabetes waiting room. What happened to these missing patients? Are they dead? Did they have admissions? Or have they had a serious complication?
And with that, we'd like to thank everyone for their kind attention. We've gone a little bit over time, but I hope you've enjoyed the case. I've certainly enjoyed bringing it to you with my co-presenter, Dr. Hani. Back to you, Dr. Fathia.
Wow, what an excellent case, a very comprehensive case that you made my task for, Q&A, I think is very easy now. Really, you had invested a lot. I know about this. You've been investing a lot in this case, and you've been connecting over several days in order to make this case, and, pass this very comprehensive information to our colleague who still, I'm glad to say, they're connecting with us over 500 till now. That means they're enjoying it. And I know that you've been even early up this morning, 5 a.m., you and Hani, to compile it together. Thank you very much for this excellent case.
Welcome.
Now, we need just to move on some of the, questions that we just, received. Is around 19 questions maybe there. And I have also prepared some of my questions as well. So I'll start with Khadija. Why you think the Emirates Diabetes Society guideline has chosen a younger age group, 30 years, as a screening age for a diabetes compared to the ADA guideline?
That's an excellent question. And it's really based on the fact that we looked at our population demographics. We've had surveys done in Dubai, in Abu Dhabi, in the Northern Emirates. And as I've shown you, all those surveys had actually seen that our patients have their disease and disease burden at quite a young age. And therefore, we thought leaving these patients until the age of 40, as what the American guidelines suggest, we would be missing quite a large chunk of the population. And if we miss the diagnosis, we allow them to develop the complications and so on. And therefore, as a result of that, given the high prevalence of the disease and our population characteristics, we chose to use an earlier age of 30 years.
Sure. Thank you, Khadija. And that takes me to Dr. Tamim. What about the cardiovascular trial, where, mostly done in Western societies and does not apply to our patient cohort? So what do you think?
I think this applies, excuse me, to many, many trials. I think you have to adjust your patient population. Luckily, we have in Dubai a variety of 200 nationalities. The trials give you an idea of what's going on. And I think at the end of the day, it's your clinical practice and your patient. But I think when you have such a heavy body of evidence, and I think there was major issue actually that actually one of the people who are on the guideline, the American Heart Failure, they were objecting to the idea that some of these trials did not have Black patients. And that could have impacted the response of those patients, which is a legitimate sort of concern. I think there are variations. I mean, within a particular trial, for instance, in the DECLARE, dapagliflozin has really one statistical aspect on the cardiovascular death and heart failure. Yet in DAPA heart failure, it's a robust results. So I think you get the cumulative sort of look over the whole trial, and then you see the trend. And I think this is when we get the messages from the trial. And subsequently, you have to, the case is what they have presented is interesting because you can go multiple ways. What's the blood pressure? How volume? So these issues, you gather all the information from the trials and you try your best to address all the elements in the patient risk and hopefully get a better outcome.
Thank you, Dr. Tamim. Dr. Hani, why diabetes are prone to higher percentage of cardiovascular disease? Is this specific to the pathology, which is just unique for diabetic compared to the other disorder, which are, mentioned in, a couple of slides that Khadija and Dr. Tamimi had shared?
So it's an outstanding question. Epidemiologically, we know that cardiovascular disease is doubled and heart failure is even higher in the diabetic population. We believe there are two distinct mechanisms. One is the premature atherosclerosis and the effect on the vascular component. Two is what is now being more clearly described as the diabetic inflammatory cardiomyopathy. So even in the absence of coronary artery disease, there's the position of glycosaminoglycans and inflammation and fibrosis. Even the epicardial fat is inflamed. There's interstitial edema within the myocardium and replacement of the myocytes with fibrosis. So there's a fibrotic necrotic component, which is like a restrictive cardiomyopathy. And there's also the ischemic component. And of course, the poorly controlled diabetic with hyperlipidemia can have both. So it's a double hit. And I think, Dr. Hassan also has a tremendous experience in vascular biology, and maybe he can enlighten us, because this is why we use RAS blockers, even in non-hypertensive patients with diabetes.
Right. Any comment, Dr. Tamimi?
Yeah, I think it's really about the vasculature. And I think why would, for instance, I have this cardiovascular risk sort of circle. Why would a blood pressure medication work in hypertension, post-MI, heart failure, and many other issues? It's nothing to do with blood pressure. For instance, take ACE inhibitors. They have all this indication, yet take calcium channel blocker. You don't use calcium channel blocker in post-MI and heart failure. It's contraindicated, yet it's a very good antihypertensive. The element of this medication achieving such a wider spectrum is to do with the vasculature. The endothelium primarily is the gateway to health, nitric oxide. Yes, we talk about it, but I think all these result. And actually, SGLT2 inhibitor, there's a good body of evidence to link it to stiffness, reducing stiffness, particularly measuring it through the peripheral. There is a technique now to measure stiffness, and you can, one of these components, why such a medication has a wider spectrum as far as the vasculature is not beyond glucose, beyond blood pressure, beyond diuresis. I think there's multiple issues going on. And I think ACE inhibitor is a prime example of the direct effect, the difference even between an ACE and ARB, one having bradykinin, which is really nitric oxide, versus one does not. And that impact on trial with post-MI and heart failure. So I think it's all about the vasculature. It's really how much you impact the vasculature and how much you damage it. And therefore, you need to start the repair process, and that's prevention.
Thank you. Khadija, you had mentioned that, the HbA1c is, sometimes is affected by several conditions. So there's a question from the audience about why does rheumatoid arthritis show a low HbA1c?
It is a really good question that I don't have any specific answer for. I would speculate that it might be related to the pathophysiology of the disease that maybe is causing a change in the RBC turnover. Perhaps for the patients who are on biologic therapies as well. But I couldn't pinpoint a specific reason why the hemoglobin A1C has just been observed that the A1C might be inappropriately lower in patients with rheumatoid arthritis. I would guess and speculate that it must be something to do with the red blood cell turnover.
Khadija, as far as I know from our rheumatologist who's based in Dubai Hospital, that the use of the biological in about 30 to 50% of the patient with rheumatoid arthritis, the alpha TNF may affect the insulin sensitivity, and it may lead to interfere with the low A1C. There's about 3 publications on this, which I did search, and I just also consulted a rheumatologist colleague while you were.
Thank you. Thank you for helping us out.
If anyone is, interested, there's a paper by Moeller and one paper by Bradley. And
Excellent.
The other, from the comment from my rheumatologist, that probably that the peak age of the rheumatoid arthritis in our area is the age of 20. And we know that diabetes, type 2 diabetes is, mainly in the age of 40 in the Western society. So
Absolutely.
that's another reason. Observational bias in that.
Right, it's good. So we learn everything, learn something new all the time. Thank you.
I did as well, asking my colleague, Dr. Jamal Saleh. Thank you for him if he was, connecting with us now. Now, the other question that I want to pass on to Dr. Tamim, should we still consider diabetes type 2 a cardiovascular risk equivalent?
But it's not equivalent. If you have diabetes, you have cardiovascular disease. Whether you see it or not, this is irrelevant. I mean, it's quite simple. We have prevention. Those patients who do not show to have heart failure, they benefit from medication that impact heart failure. So I think the manifestation of the disease, it's way ahead of time. I mean, if you're waiting for a patient to manifest their cardiovascular problem with diabetes, then you have missed the boat. A diabetic patient for me is the time bomb. And I think you need to act. Now, as far as Dr. Khadija raised the issue about who is prescribing, I think we should all be prescribing. I think there was some fear issue that I hope the cardiologists, internists, everybody should get out of the way, because these medications are really there to be used effectively against such a widespread vascular disease. And therefore, I have worked with my endocrinologist colleagues, and I really, I have to make sure that those patients get on this medication. And luckily, it doesn't become a sensitive issue, but I have to make sure that those patients, yes, you can adjust the A1C, but they need to be on medication that will improve outcome and prevent death and cardiovascular morbidity and mortality.
Thank you very much. That takes me to Dr. Hani. After the result of recent studies, should we still consider SGLT2 and GLP-1 as a class effect, or we need to specify drug effects, especially in the guideline?
So very good question. In the GLP-1, they're clearly heterogeneous, right? There are literally only 2 GLP-1 or 2.5 GLP-1 that have evidence of cardiovascular benefits. So we won't go through the older ones that were the exendin-based pathway and so on and so forth. And I think this is really clear that only the dulaglutide and primarily liraglutide and its subsequent precursor of semaglutide have strong cardiovascular outcome. And of course, the utility of these drugs has to be highlighted. In SGLT2, there is a heterogeneity in one aspect. That's the MACE aspect, right? I think Dr. Hassan mentioned it very nicely. In the EMPEREG outcome study, patients with ASCVD actually had a MACE benefit, reduction of triple point MACE. In DECLARE, this was only seen in those patients who had a myocardial infarction, not all patients with ASCVD, but across the board, every single one of them, everyone, 4 agents, 4 studies, heart failure benefit across the board, renal benefit across the board. And that's plenty. Heart failure is lethal, and you don't really have, as we've seen, don't have to have a cardiovascular event to have heart failure and diabetes.
Thank you. Dr. Khadija, what is the maximum dose of SGLT2? Is it possible to use 2 of SGLT2 at the same time for the same patient?
Wow, that's a very interesting question. So the maximum dose is to follow the label guidelines for each agent. So for empagliflozin, for instance, it's 25 milligrams is the top dose. For canagliflozin, you can go up to 300. For dapagliflozin, it's 10. And I haven't had a chance to use etugliflozin, so I'm not really sure what their maximum dose is. There is really no benefit of combining 2 SGLT2 inhibitors together. You can use the SGLT2 inhibitor with other agents, such as a GLP-1 receptor agonist, metformin, but I don't see the utility or the benefit. And we haven't had any studies that actually have shown that if you combine 2 different SGLT2 inhibitors, you will get an added benefit. On the other hand, I would actually maybe worry about introducing risks of other things. Maybe you increase their risk for genital infections or urinary tract infections, but I haven't come across any studies or any papers that have actually suggested we use 2 different kinds of SGLT2 inhibitors simultaneously. The rationale would really be to use agents that would target the other pathophysiological defects in type 2 diabetes. So combine your SGLT2 with metformin. It can be combined with the sulfonylurea as well, if you really want to lower the glucose. But I don't really see the rationale of having two SGLT2 inhibitors in the same patient.
Thank you.
I don't know if the others have any other thoughts on that.
Okay, can I just go on with the question to Dr. Hani? Why is SGLT2 not proven for heart failure with the preserved ejection fraction and or 1% can work?
So I might actually disagree with that concept just from a general standpoint. Yes, there is no clinical study except the ones that Dr. Hassan showed that included only HFpEF patients. But let's remember, in the DECLARE, EMPEREG, VERTIS, and CANVAS, there was a 46% reduction of new heart failure. In these studies, only 10% of these patients had a low ejection fraction. That means that the rest had a normal ejection fraction. So it's impacting the clinical dimension of heart failure, which is lower limb edema, fatigue, shortness of breath, pulmonary edema, and hospitalization. And I think we're going to see, as Dr. Hassan showed, this is a very pleasant surprise. For decades, we have seen nothing that works in HFpEF, nothing. And now we have an agent that has a potential benefit in patients with a normal ejection fraction. So I think we have to just stand steady, wait what's going on. But clearly, a diabetic patient with any kind of heart failure, normal or reduced, benefits from SGLT2 inhibitor. And now we're going to see what happens in the non-diabetic patients. So that's really, I think, the evidence-based answer.
Right. Dr. Tamimi, TIMI DECLARE 58 did not show any reduce of the 3-point MACE. So any comment from your side on that?
They were just sort of touching on this. I think, well, I mean, you would think, and then came a DAPA heart failure. And I think that really, I mean, you would think the signal, was it because there were a lot of primary prevention patients there? I mean, the profile of the study, you would expect Yet, I mean, EMPA-REG has excellent impact on outcome. With the EMPA reduced, there was no impact on mortality and cardiovascular mortality. So really, it's to do with patient, as Dr. Hani suggested. I think you have a trend, and I think the more studies we have, then you start accumulating. We are in the process. I mean, I tell you, everybody who thinks that know how these medications work, this is too premature. As we are doing studies, we are learning more on this medication. As I said in my introduction, usually we know how the medication works. Now we are learning from trials, and then we are making the hypothesis that, yeah, so it worked in this, it must have some effect on. So I think by the end of 2022, there will be 20,000 patients randomized in the SGLT2 inhibitors trials. That's a huge number. And I'm sure heart failure, preserved EF, and other component will be also quite clear. So yes, it does not have the full sort of benefit that we saw with EMPA-REG, but I think this is now behind us. And I think that heart failure totally corrected the concept.
Okay, thank you very much. Khadija and Hani, this question is from my colleague, endocrinologist Dr. Bashar Effendi, and he put about 3 questions in one, so I'll try to address all of them. What evaluation is required prior to starting patient on SGLT2 inhibitors?
So there is no specific evaluation that is required. Any patient, I mean, these are glycemic agents, so you can use them as anti-glycemic agents. If the patient has cardiovascular evidence of cardiovascular disease, who's got risk factors, we know now that they can also be used. So the only caution that you might want to consider is, say, a patient is on large doses of diuretics, and you might worry that they might be get more dehydrated with the SGLT2 inhibitor. Perhaps an elderly, very frail patient as well. You might use it more sort of cautiously. Patients who have got hemoglobin A1Cs that are above 10 and are very symptomatic, they've got these catabolic symptoms, because you don't want to introduce the SGLT2 inhibitor at that point and then get them coming with euglycemic DKA. So if the patient has a very, very high hemoglobin A1C, you must address that. Perhaps they're insulin deficient, and therefore, give them insulin. And then if they've still got, you want to modify, use it as modification of their cardiovascular risk, use it later on, rather than when the A1C is very high. Because we've also seen that in clinical practice, where patients' hemoglobin A1C was 12, started on an SGLT2 inhibitor, and then presented to the hospital with diabetic ketoacidosis. So those are the sort of practical clinical situations that I might think of that you would want to consider before you use your SGLT2 inhibitor.
Okay, Khadija, before I carry on and ask the other question that Dr. Bashar had put, would you still use, for example, SGLT2 in someone who's underweight or slim?
Yeah, so I mean, that's not a contraindication either, right? So if this person has a BMI of 22 and has has got risk factors for cardiovascular disease, and the hemoglobin A1C is 8, there would be no reason to think that you can't use it. You would, if you think that they're underweight and they might be LADA, or there might be a chance that this patient has got type 1 diabetes, then yes, you would have to be more cautious in thinking about using the SGLT2 inhibitor.
So how are you going to monitor, or how frequently are you going to monitor the bone densitometry, cardiac profile, hepatic, renal function when the patient are on treatment with SGLT2? So
with the bones, we're not really very concerned about the bones, because we've seen from the large number of studies with the SGLT2 inhibitors that bone fractures were not really a problem. With the renal function, we do know that there might be this slight dip in the eGFR, and we know that when that happens, the drug really is working. You don't need to panic and stop the drug. You can carry on, and usually then we've seen also that we've seen the curves that it picks up, and you can carry on with the agents. For patients with hepatic disease, I don't think there's any specific contraindication. In fact, for patients with NASH, it might actually help them, because if they lower their weight, and there are studies now, I think, that are ongoing to look at the utility of these agents specifically in patients with NASH. So unless the patient is in acute liver failure, then maybe I wouldn't consider using the SGLT2 inhibitor.
So what is the cutoff point for the estimated GFR?
According to the labels now, they differ between the agents. So some agents can go, like canagliflozin, you can go down to even less than 30 mils. Empagliflozin, I think the current labeling is still around 45. Dapagliflozin, similarly, they're still at 45, although they've got DAPA-CKD where they actually went down to eGFRs of less than 30. And then I think ertugliflozin is still at an eGFR of 60. So if you go by the product label, it's very different from what the studies are showing us. So I think, the guidelines will actually have to catch up, and the labels will have to catch up with what the clinical trials are showing us.
I think this is an important point to highlight. The reason why these labels have the GFR cutoffs are essentially based on glycemic efficacy and not toxicity. It's become very confusing for physicians to think that, oh, wait a minute, if it's less than 60, I have to stop it because it's going to make the kidney worse. This is not the case. And I think the statements that have come from the various societies are supporting that until the guidelines are actually clearly stating this.
So when we recommend stopping SGLT2 inhibitors in a selected patient?
So I guess in patients are on end-stage renal disease, because we don't have the evidence for that. So if the patient's on dialysis, eGFR is less than 15, that's the time when you would say, okay, perhaps, it's not going to be working anymore, because we just don't have the evidence for that.
Right. Okay, Dr. Tamim, one of our colleagues here asking, I have noticed that the most, one second, I've lost that question, 1 second. I have noticed that most of the precising cardiologists are reluctant to do BNP till now, being suspicious of its ability to predict heart failure. Is that true?
Not really. I mean, I think BNP is not something that all cardiologists are able to treat heart failure. And I think there are lots of studies, as Dr. Henry suggested. It's not a routine thing that we use automatically, but I think now with the correlation between outcome and BNP, I think people are far more aware that this is a marker that it will guide you first for diagnostically and then as a follow-up. But can I just comment on one thing? I mean, we are using SGLT2 inhibitor in very sick heart failure patients. I'm sorry. I mean, if I'm listening to excuse me for being a little bit forward here. If I'm listening to the endocrinologist, I think I would be very afraid or maybe a little bit inhibited. And I think, yes, there are issues. But when you have a patient who is EF is 30%, creatinine is high, patient blood pressure is hardly maintainable, we manage through. And I tell you, these medications are very, very effective and free of problems. We're dealing with ARNI, which is a combination of a huge valsartan, and so 4 medications in a patient whose blood pressure is 90, and they all work on blood pressure. So now we have an agent that's literally the mildest of all the 4. And then we're talking about DKA, and I've been using this for 4 years. Yes, I agree with the precautions, but I think we need to encourage everybody. It's not about A1C, I'm sorry to say that. I agree. I think we should work on this. We are talking about a life-changing medication. And I think people, even I personally would like primary care physician to get on board, and because they are the gatekeepers for all these patients. They are very good and safe medication, and we need to learn more about them. They are not a particular to the endocrinologist or cardiologist. These are medications that I've already showed thousands of patients benefiting beyond anything, diabetes, heart failure, the whole lot. I am very excited about this medication, and we need to make sure that people are on board.
Okay, thank you very much for this. Dr. Hani, someone is asking about the insurance. Just let me get that question.
Yeah. So I think the question is, how can you use tests for screening? The question isn't about screening, right? The point is you have to ask the question. Does the patient have shortness of breath? Yes. Do they have lower limb edema? Yes, I am suspecting heart failure. It's not screening anymore. The patient is symptomatic, but you have to probe them for the symptom, right? Don't expect the patient who's been sedentary for a year to tell you, Wallah, doctor, I can't play tennis. They don't play tennis. They don't even go up the stairs. So the logical thing is you probe the question, do a physical examination, edema, pulses, gets back to the stethoscope, leave the epic and listen to the patient. And this will help you to establish, I need to do a BNP to establish that I know this. I need to do an annual ECG because I have a high risk of cardiovascular disease. I need to check the pulses, and if they're abnormal, I want to get an ABI. As a clinician, I can justify anything within reason by having a clinical perspective.
So this question, related to the primary care, as you had yourself touched, and Dr. Tamimi on this. So is the insurance cover for screening for CHF, CAD is a major limiting factor in primary care? And the other question is that the primary care physician role in the first step in cardiometabolic control.
Yeah, and I think this is key, because here you have a patient who has had hypertension for 10 years, never had an echocardiogram. Why? I think we need to involve and engage, because most of these patients, they don't come to me or to the endocrinologist, they go to the family practice with their diabetes, with their hypertension, with their chest pains, with their whatever. So we need to triage those patients quickly. I would like to see. Now, I tell you, many, many times, I see patients coming with shortness of breath. They've been put on diuretics. You do an echo, the ventricle is so thick, they have heart failure, EF is, and I'm like, oh my God. And you can do far more. And not all antihypertensive work the same.
Sure.
It's not about controlling the blood pressure. So the issue here is we need to involve the cause, the issue. Once you have, for me, a patient who has diabetes should have an echo done as soon as possible. We need to see, it's not about EF. The diabetics have amazing, funny ventricles. And whether it's low EF, high EF, the same, they have infiltrative disease, and that's diabetes. So I think we need to involve, and I think Dr. Hani, myself, and a few of the endocrinologists, we had some sort of club we used to meet, and I think it was the most informative sessions where endocrinologists, they have this new concept about heart failure. We need to learn about diabetes. We need to know the other drugs, and then share the information. But the most important concept is patient cannot be treated on the traditional medication because your A1C is good, go home, your blood pressure is fine, you're on a diuretic. I'm sorry. Diuretics are very good in hypertension, but they don't have any outcome benefit. They're very cheap, but who cares?
Thank you, Dr. Ami. Now, this is one question from another endocrinologist, Dr. Maher Jallo, who is asking about, now we have enough, or we have used SGLT2 and GLP for many years and all over the world. So do we have any global data that the cardiovascular was really declining globally, Dr. Hani?
Yeah, so we have the Swedish National Register, which is a vast register. It's got like 2.5 million patients. And it's very clear that the traditional risk factors for CVD are decreasing, except they're not catching up in diabetics, right? So in the non-diabetic population, they've had a substantial reduction because of cutting down smoking, treatment of hypertension, treatment of dyslipidemia. But in the diabetics, the gap is still there. It's less, but the gap is still there. And as the population ages, this gap is going to close and start going back up again. So the Swedish National Register, they publish basically annually. It's phenomenal. We also have the Euro Prevent. These are the Euro Aspire series of studies. There's 1, 2, 3, 4, and 5 now. Very powerful data from registries all over Europe. Again, the death rates from MI are decreasing because of primary PCI and intervention and high-cost innovations. But prevention-wise, we're not doing everything we can. And as Dr. Hassan mentioned, upstream prevention in the primary clinic is so valuable that the WHO has called it the best buys, right? Upstream, just treat everything as early as possible. And therefore, you don't actually even see these horrible complications that we see in the clinic. So,
Sorry, and if I'm showing that the number of prescriptions are so low, how can we look at the impact if they are not used?
Yes.
Look at even endocrinologists in the GLP-1 and the SGLT2 inhibitor, the number of prescriptions is very low. So yes, we are excited about the trials, but to have an impact long-term, you have to use them as you would use the ACE inhibitors, the beta blockers on that level. Then you can appreciate an impact long-term.
We have a lot of catching up to do.
Sure. Dr. Hani, following the question I just asked you, this is again a comment from Dr. Maher, but this decline is not due to diabetic medication.
No, it's not. The decline is generally due to other background risk factors. So I think what's very clear is that the universal adoption of statins, huge smoking cessation programs in Europe, again, that's what it is. The diabetes people still have a higher risk, but their baseline risk is decreasing. They still are double the risk of the non-diabetic patients. So with these kind of disease-specific medications, and I mentioned specifically GLP-1 and SGLT2, there's a chance to impact this mortality and get them away from that massive amount that you see in the placebo arm of all the studies. If you look in the placebo arms in the diabetic studies, remember the cardiovascular event rates are almost double those of the PCSK9 studies, right? In the PCSK9 studies, the average was about 11% in the placebo arm. In the EMPEREG, it's basically 27%. It's enormous. It's really, really outstanding that we have all of these powerful agents and the universal adoption isn't there, right? So I think it's statin use, RAS blockade, and smoking cessation, not the use of diabetic medications, but I think we can do it. I'm pretty sure we can.
Khadija, from your experience, many patients have unrecognized acidosis on SGLT2, for example, like lactic acidosis or tubular acidosis or DKA.
Not really. I mean, we've had definitely a number of patients that have come in, but I think that those prescriptions were inappropriately placed in patients that actually had very high hemoglobin A1Cs when they were given the SGLT2 inhibitor, when actually they needed to have insulin. It may happen sometimes in hospital where, for some reason, maybe the SGLT2 inhibitor wasn't discontinued, patient has been kept NPO for whatever procedure. They may then also develop acidosis. So we're not seeing as many cases. I mean, it's something to be aware of, but it's not something that we're seeing very frequently in clinical practice. That's what I would say.
If I could just add one small comment, I think one of the problems is this patient is not on a medical ward and they're tachypnic because of acidosis. The reflex, and we've seen it with some of our surgical colleagues, is to give more furosemide, which causes more renal worsening. So checking the ketone bodies is critical, and this is where it's tricky because we were taught in medical school, high glucose, check ketones. This is normal glucose, again, check ketones.
Right, now, because we are doing this cardiometabolic, and I would like to ask this question before we close, Dr. Hani, Khadija, and Dr. Tamim. Is the risk of recurrent MI is highest in the first 12 months, because you had addressed this in your talk? And should we need to combine both GLP and SGLT together?
My vote is yes. And I think out of abundance of resources, we see the patients frequently, and we actually do that, but we don't do it simultaneously. Maybe we do a 2-week step between them. There's a lot of education involved. Where, you know, as a cardiologist, I've learned a lot about the GLP-1 class, how to actually prescribe it, the up titration, which is very important. I think if you just go for gold, it's unlike we do in statins. You should really titrate these things slowly. And we have the benefit of excellent diabetes educators from which we have learned and we teach our patients. And that's something we don't have in a traditional cardiology clinic.
I think trials, really. We need the trials to tell us that these combinations are effective and safe. I think it's possible. I think it makes sense as far as the mechanism, but I think we need to wait the trials.
We can conduct one of our own, Dr. Tamim.
Yes.
But there have been trials that have combined the SGLT2 inhibitors with the GLP-1 receptor agonists, but these were mainly for glycemic optimization. We don't have evidence that the two together would increase your cardiovascular benefit. So yeah, so we're using the two for their individual cardiovascular benefits, but the combination, we haven't yet proved that really does it.
Khadija, then how about those patients with pre-diabetes and they post-MI? Would you manage them the same way that you are managing your diabetic patient?
Yeah, so we've said that even pre-diabetes is also, again, a high risk. And so if they've already had a cardiovascular event, we're not thinking about the glycemia here anymore, right? We want to modify their cardiovascular risk. And therefore, again, this patient, if they've had an MI, the SGLT2 inhibitor should be on board. If they have pre-diabetes and they're obese, your GLP-1 receptor agonist can also be used. So because we know that we're also going to be using these agents in people who don't have diabetes. So why would I deny it for a patient who has pre-diabetes?
And one more, Khadija, because I know that the people are keen and there are so many questions. I'm sorry to keep you late, but I think we need to address, because still around 400 plus waiting with us. So I don't want to deny them the answers. From your experience, if the patient on GLP-1 responding well in the initial few years or few months of the treatment, and in terms of the weight and A1C, then later they did not. So what you will be doing?
That happens very frequently, I would say, in clinical practice. You may get that initial dip and then they kind of plateau. And then you would have to use other means. Fortunately, now we are having more and more potent GLP-1 receptor agonists. So you might want to switch, say, if the patient was on liraglutide, you want to switch them to semaglutide, which would give you a greater reduction in their weight, as we've seen from the clinical trials, and now we're also seeing in clinical practice that the weight reduction is much more superior with semaglutide as compared, say, to liraglutide. Then, of course, you would want to also address the patient's dietary intake. What about their physical activity? You know how our patients are. It's a chronic disease. They do tire from all the restrictions that we put on them. So the patient may be motivated initially to take their meds on time. They're more careful about what they put in their mouth. But then over time, that kind of dwindles as well. And you might have to readdress that and then, send them again to the dietitian and revisit what it is that they're eating. So yeah, there's those kind of different ways that you might use.
Thank you. And I promise it's my last question. Who should champion the cardiometabolic clinic? And this question is open for 3. Is it
CKD, right?
CKD, yes.
All 3. And the primary care physician.
Absolutely.
Absolutely.
Unanimous agreement.
Someone had also posed, in the chat box, what about nephrologist?
They're right in the middle.
Yeah.
CKD.
Welcome.
Sandwich.
Thank you very much. Thank you very much, really, for this exciting, part 2 of the Cardiometabolic Academy. I thoroughly enjoyed it, and I'm sure all our audience had enjoyed it, because as I told you, there's already 400 plus who's still, awake with us till now. Many thanks, Dr. Tamimi, for your excellent contribution.
Thank you.
Ani, I cannot, thank you. You've been really, working hard on this. And thank you very much, Khadija. You all did a great, great, great job. Really, many thanks for this. And we also, look forward for the, coming webinars as well. So and also I would like to thank our audience for their also patience, and they've been also, interactive with us with many questions. And I apologize for those who I was not able to take the questions. And thank you very much, and have a great night. And I also just want to remind you that this is accredited CME hours of 2 from the Dubai Health Authority. You will be obtaining those CMEs hours within 10 days after you fill the evaluation form, and then you will receive your certificate. You could find this, if you want to go back and listen to this exciting, webinar, then you can always go back to the EDS website, and you can find, the webinar on demand as well. And also, we would like to encourage you also to attend our future activities, and you need to just block your calendar. These are, different activities that the society is doing. And we have also, the 2 part 3 and part 4 webinars on 28th of June, and also part 4 on 5th of July. Myself and Dr. Hani, we still have, some work to do with the rest of our colleagues in the coming 2 parts. Thank you very much, and wish you all a great night.
Thank you. Bye-bye. Good night.
Thank you. Bye-bye. Good night.
Thank you very much, Dr. Khadija. That was fantastic.
Thank you.
Absolutely.
That's true.
Yeah.
Assalamu alaikum.
Bye-bye. Thank you.
Bye.